Hello, thank you so much for being here for our second webinar in this series. This time we're going to be covering the conditions of the knees, the hips, and the lower back. My name is Dr. Kevin Wong, and I have been a chiropractor for 21 years, and I've been using laser therapy through Cutting Edge for almost 9. I've been teaching in our profession for almost 21 years as well. I teach a lot of extremity adjusting, and I've been incorporating more and more laser therapy through all of my treatment. So this is where this webinar is going to be hitting you, trying to give you some exposure to some of the things that we do in practice and how we can use laser therapy to help conditions that we will see. So that's me, and that's my little girl. My little girl is in 6th grade right now, but this is a good way to get a hold of me. This is my app. I give it to you early. I will also show it to you at the end. Some of you who may want to get a hold of me, just go to that website and it'll install my app on your phone. You don't have to look at my app all the time. You can just put it in a folder like the chiropractic folder, and then you'll have a way of being able to email me or contact me if you have any questions from what we've talked about here, especially if you ever have questions about the laser that you're thinking of or about some of these things that we're talking about today. All right, so let's jump into this. I really want to make sure I am explaining things well to you and that you understand and learn instead of memorize. When we memorize things, we have a tendency to forget them. So I want to make this very obvious to you. So we're going to start with the knee and move through the knee itself. As you can see right there, we have the patella, you've got your femur and your tibia bones, and of course, your fibula. And you can see from this that it is a right knee. And I think what's so interesting, and I want to make sure you understand, is that in the world that I live in, a lot of the conditions that will come into me have to do a lot with the people's feet. They don't realize that their feet are fairly flat. And in some respects, about 8 out of 10 people are pronating or having collapsed arches. So when they come in and I take a look at them, a lot of these people don't realize that their feet are an issue. And their feet are directly related to how the pressure comes up from the ground through the axial kinematic chain and hits that ankle and then hits that knee and the hip and the back. So some of what we're talking about today is just an understanding of how things kind of work with people's feet and how that can put stress on their knees. Now you're going to see quite a few people that come in with knee issues. They will have medial issues, they will have kneecap issues. They will be coming into you with diagnoses that they've been given by their medical doctors. And this may or may not be true. So it's really up to you to figure this out. So just be familiar with your anatomy, because even though the knee can seem simple, and it often can be simple, we just have to make sure that we're catching our patterns, all right? Now I like this picture because it really shows you well the menisci. You got your ACL, you got your PCL, you got your medial lateral meniscus, a lion's share of your problems that come in the office. And I want you to think about this to your own practice right now. Think about the last knee patient you treated, all right? The last knee patient you treated more than likely had medial knee stuff going on, especially if it was an insidious onset of pain. A lot of these patients come in, they do not know why their knee pain began. They're very confused. Now, if there was a trauma, that's a little different. You can have knee pain all over the place if there is truly trauma. And depending on how heavy your sports practice might be or how heavy you treat a lot of runners, et cetera, you may find some different parts of your patient demographic. But me, I live in the world of insidious onset of pain. And it's almost always that medial knee. That's very, very common. And why, again, is that? Because if you stand up right now, do me a favor, my friends, just stand up for a second while you're in front of the computer. I want you to make sure, even if your shoes are on, it doesn't really matter, because most of you don't have your feet as well supported as we could be. So if you roll your feet all the way in, you're simulating pronation to an extreme. Some of you have it mild, some of you have it moderate, some of you have it severe. But the more your feet roll in, you can start to feel the pull that the tibia and femur bones go through as your feet collapse, all right? You can feel that pull on there. You can feel the pull on your medial knee. And you can also feel the stress on your kneecap. It's pretty common that this happens out there, and that's why I want to keep making you aware of it, all right? So in our office, we will tend to see a variety of things: ACL tears, PCL tears, meniscus. the collateral ligaments, medial and lateral, patellar tracking disorders, and of course the classic arthritis. You and I both know that we hear arthritis a lot being thrown out there by medical doctors. And for whatever reason, it may or may not be true, but it gets blamed for a lot of things, all right? Now, one thing I want to make sure you understand is you can use laser for anything in the body. What's so beautiful about the lasers is that even though we have a class 4 laser, and some people will say to you, oh, class 4 is really powerful, it creates a lot of heat, it does this. No, our CE lasers are wonderful machines that create no heat and they leave no side effects. So when people talk about laser like they know what they're talking about, a lot of people don't know what our company does with these types of lasers, and they've been out there doing these lasers for quite a while. These are Italian. All the cool stuff comes from Europe. We know that the cutting edge is one of the top lasers in veterinary medicine. And then along in the human medicine side, they're making more strides and they're getting even more popular as time goes on. Like I said, I've had mine for almost 9 years, and it's been just a fantastic tool. I have the M6, all right? There's the MP5. And then the MP, that's more of a unit that the veterinarians will use, or it's also a good portable unit for you to have when you do a lot of your sports events, all right, or you want to do things from home. Now, this is our classic chart here of how you can change and modify the dimensions of treatment area, maintaining the same energy density. So if when you mess with your controls and you're trying to find the optimal dosage for the body part, this is that flow chart that you're going to use. I'm going to show you screens from my laser on various body parts as we go through from the knees up to the hips, etc. All right? I will show you my settings. So this way, later on, if you're like, oh my God, what was that setting Kevin was using? These are settings I've used for years. And on my model, it's got the settings that are preset in there. You may have a model where you have to set your own, and that's okay, because that's why I'm showing you the screenshots. You'll have access to the webinar later where you can go back and you can look at my screenshots, and I actually do repeat a couple of these. So, all right, so this is my knee pain setting. I put my intensity at 100% for just about everything. If it's really, really, really acute and really painful is where I leave it at 50%, but it doesn't stay there for long. By frequency in hertz, the rule of thumb, again, I will repeat. The more it hurts, the higher the hertz. The more it hurts, the higher the hertz. So I may bump that up to about 900, or I might bump it up to 1,000, depending on how much pain the person's in, okay? And the time, again, there's an optimal dosage time, and if you go too far over that, it really doesn't do much more. You know how our saying in America is, if anything that's worth doing is worth overdoing. Well, in this case, there's a certain threshold where you're not going to get much more benefit. So don't think you got to turn the time up to 20 minutes. It's just not, keep it, around those settings that will change as you mess with your hertz, and you'll see your joules change also. All right, but again, the X and Y amplitude you will change, as well as the height of the head of the laser. All right, and if you have an MC5, you're going to be able to just use those little knobs to get the head positioned in a certain way. And remember, when we start this treatment on the knee, we are going to see where the most pain begins. Then, as treatment improves over the course of your 6-7 treatments, you will be able to move that laser head. If you have an MC5, you'll be able to move it to where the pain is worse. When we have an M6, you're basically scanning that entire area. So you're going to be capturing a good amount of area. I always am an advocate for the M6 over the MC5. If you're going to spend the money, get the one that's the robotic head, so you can basically cover the whole treatment area during the time for every visit. And you can still move the M6 around, maybe in the front of the knee, or the medial part of the knee is where we begin, and later on you kind of end up more on the inferolateral part of the knee, depending on what the patient needs. Okay, it's always on a case-by-case basis. So when we look at adjusting as chiropractors, we're also looking at how can we fix this knee? What's going on with our patterns and what can we do? I've already told you the lion's share of these people that will come to you are going to have an internally rotated tibia and femur. They'll have a medial inferior patella, and their fibular head will probably be posterior superior, although your hands will tell you which way that's also moved, all right? So we can use different types of adjusting with our hands. Manual, diversified, we can use our drop table, we can use those spring-loaded instruments. Here are some of those examples, just so you can remember. I'm not in front of you, so I can't go over the hands-on session right now with you, but I can at least explain this as much as I can, all right? So what's really interesting here is we have a variety of tools at our disposal, and I want to encourage you, as someone who's taught technique for over 20 years, chiropractic began with the hands, but there's no shame at all in you being able to make sure you know how to use the tools that are at your disposal, all right? These tools are really important. Okay, let me see what happened here. The first listing that I want to go over with you is the external or medial rotated tibia, all right? The tibia, again, what we're going to do here is I have the patient laying supine on the table, and there's a pillow underneath her knee or a bolster, and I'm taking my hands and I am putting them above the kneecap. I'm putting them also below the kneecap, and I'm grabbing the distal tibia and the proximal, the distal femur and the proximal tibia. You can see that right there. So I can feel with my hands which way her knees have rotated. I can get in there, I can feel that medial joint line of the knee and see if it's very sore or tender or swollen in there. Basically what I'm doing with my hands is with my left hand in this picture, I'm taking her distal femur, I'm grabbing it and I'm pre-stressing from internal to external. And then with my right hand, my thrusting hand, I'm taking her proximal tibia and I'm going to take a nice little pre-stress from internal to external. What I'm doing is I'm opening up the medial joint line. All right, say you had a supinator. The supinator has the opposite effect on the knee that the pronator will have. The supinator is when you stand up and you roll your feet all the way out, and you feel the person has a very high instep, and their feet are actually rolling the opposite way. That will actually give someone lateral knee pain, and that's one of those areas that you look for when someone is complaining of knee pain on their lateral side or near their fibular head. So I can manipulate that knee either way. I can do an internal to external pre-stress, or I can do an external to internal pre-stress, depending on what I feel, all right? So that's what the internally rotated tibia will look like, and the externally rotated looks the same way, just the way that I'm going to move my lower hand. Am I going to take a tissue pull or a pre-stress internal to external or external to internal? Either way, but I can control her knee very nicely. There's no real thrust here, my friends. It's more of an impulse, all right? There's no real thrust on this. So when we look back just at the external or medial rotated tibia, your thumb web contact is going to be with both hands stabilizing the femur, put the cushion underneath the knee. You can also do a drop table move on there where you just cock the drop piece and use that piece to fall away so you have a gentle adjustment of the knee. Or you can use the activator. And when you use the activator, again, what you're doing here is you are just trying to open up the medial joint line, trying to help to untwist the knee bones, all right? Now, there are situations where your tibia can go posterior. How would you know this? Your patient is prone. You're putting your hands on the posterior portion of the knee, checking out the tibial plateaus. You can actually feel that tibia pushed backwards towards you. And when you run your finger along that posterior joint line, it's tender for the patient. They'll feel that, especially on the medial portion. Remember, a lot of these people, since they're pronating and their feet are rolling in and dropping down and flattening, it creates an internal rotation of that tibia, and you can feel those plateaus on the inside of the knee having gone posterior and rotated out a little bit, and it's very sore on the medial knee on the back of most people's knees, probably yours as well. All right, so you can either adjust the posterior tibia when they are supine and their knees are bent, almost like you're doing an anterior drawer test on the knee, or when they're prone, you can do a bent knee with a knife edge contact or a thumb web and get that tibia to try to move forward, all right? We're always able to use the drop table and always able to use the spring-loaded instrument, all right? So the fibular head, don't forget with the fibular head, what's really important here is when you have that patient prone and they're on their stomach and you get your fingers on that fibula, the fibular head will always move in response to what the tibia and femur have done. I found most of the time those to be posterior superior. We can get a little bit of laterality on that, but you're going to get your hands on there, do some motion palpation and wiggle it around. You'll be able to figure out how it's moved. And I often will use an activator because it's so easy. Yes, you can do a manual adjustment similar to the one that you did for the posterior tibia by just sliding your hand out on the fibular head. Often I can get those both to move if I'm going to do a manual adjustment with doing the posterior tibia and the posterior fibular head, all right? But again, activator works really well, and it's just, again, using your tools that you have available to you, all right? So now, the patella itself can also drop inferior, all right? So when we're supine with the knees bent, this is the picture of that where I've got the patient with the pillow underneath there. I've got a thumb web contact on the inferior patella, and my line of drive is going to be basically 45 degrees from medial to lateral and a little bit I to S. Again, taking the activator or taking a drop table approach as well will all work. I'm just trying to give you as many ways to adjust this as you possibly can. I want you to be comfortable with adjusting the extremities and not shying away from this. If someone says, oh, you have knee pain, you can deal with knee pain better than a lot of the other types of doctors out there because you know biomechanics. You know how to move things. When we combine the power of the laser to take down swelling, inflammation, and edema and muscle spasm, and we combine that with our adjustments, it's a very powerful thing. I just do so many laser treatments on knees, all right? Now, the different kind of supports for when they leave your office, because I do encourage you to think about supporting the knee when they leave, because some of these people, as you will find, they don't have good shoes, they don't have good orthotic support. So when they go out there, they can really, their knee can become under fire again and start pulling it out of place. So I use a lot of sports tape. I do some braces sometimes, but I will use sports tape because the sports tape is thin. It is very, it doesn't create any drag when someone plays sports, and they can do it themselves and get the tape from you. A lot of these knee braces are bulky, all right, and obviously there's an example of types of orthotics that you could put in the patient's shoes if that's something that you believe in. I happen to believe in that very heavily. So now, if you do have a good enough pair of orthotics underneath the feet, what that's supposed to do is it's supposed to absorb the shock that you will get whenever you take a step. We get 5 G's of shock at the calcaneus bone every time we take a step, and that 5 G's in a normal foot that's healthy and the arches are working, it'll absorb 30% of that ground shock before it starts going right up the leg bone into the knee. If you've got somebody who's pronating or supinating, they have lost that ability to absorb some of that ground shock. So more of the G's of shock is going to come up and hit that knee. You see this picture of the X-ray, that is one of the most common things we see that just helps me make my point that the medial knee is one of the most common areas of arthritic degeneration that we see, all right? So again, there's the healthy joint space on the left, and then there's the arthritic one on the right, and it's on the medial side because there's our fibula on the left, which means that's the lateral side of that left knee, okay? So also a good pair of arch supports is going to decrease the extent and speed of the pronation and reduces your medial rotation force in the knee and the spine. I mean, this is a lot of what we do is trying to understand the biomechanics of the body and how to get in there and support it so that they hold their adjustments for longer and they calm the pain down. All right. I was alluding to earlier that excessive pronation that most of these patients are going to show up to you with will produce the internal tibial rotation. It'll create patellar tracking problems. You know about chondromalacia patella and the medial knee stress. And then that will create problems with the ACL. That can create problems with the ACL, the medial meniscus, the medial collateral ligament. Those 3, by the way, you know as the terrible triad of the knee. And then, of course, can create arthritis that we see again. You have probably seen this in your family and some of your patients, and guess what? It could be you, all right? Now, what are predisposing factors to lower spine instability? The knees will lead to hip and lower back issues. Sometimes you can have them at the same time, all right? Also, previous soft tissue injuries of the lower extremity. Most of these people out in the field that we see never think of the chiropractor that could help them with a foot, ankle, knee, hip issue. They only think of us as back and neck doctors. They pigeonhole chiropractors as being spine only. I've made painstaking efforts over the 20 plus years I've been in practice to make sure patients know that I am way more than that. And when we are able to adjust and treat their extremities for them, we can help them to avoid pain down the line that can come up in the next joint along the axial kinematic chain. So when I say previous soft tissue injuries, I'm talking about people that have had ankle sprains that never saw the chiropractor, that had plantar fasciitis, Achilles tendonitis, shin splints, Osgood-Schlatter, all these types of things that can affect their body that they never think that we can adjust them, and they never realize that we can fix this for them and help them. Where's the number one location of degeneration in the body? So I want you to think of spine first here, and you would know that it's L5S1. Absolutely, all right? That makes the most sense. It bears the most weight. But I'll bet you, number two, you might not think that it would be the medial knee. All right. Again, why am I making sure that I really hammer this home in this part of the lecture? Because you are intelligent. You can figure this stuff out. We don't need an MD to tell us something that you know just as well, if not better. The medial knee pain is there. When they look for this, they take an x-ray. They go, oh, I need to send you to the orthopod because you probably need a knee replacement. And that may be the case. But guess what? With your adjustments and your ability to know how to support the feet, et cetera, support the knee, you're going to take away the biomechanical stress that's creating issues there. When we use laser for any type of arthritis, it's very rare that laser can't help an arthritic patient. I guess in my cases where I could say my laser hasn't been quite as effective is when they're bone on bone, because there's no water or fluid left in that knee for me to move around with my laser. But if there's mild, even moderate degeneration, we can help these people by putting that light on there and helping them with our adjustments and our support so they can avoid the knee surgery. Because the orthopods, they're licking their chops. They want that surgery. They can't wait for it, okay? Now, shin splints. Some of you have had these. You've treated patients with these. You're going to see them. It's pain, aching, and tightness in the anterior group or posterior muscle groups of your leg, all right? So what happens here is it's an overuse injury, and it's an inflammation that's going to affect the muscle, tendon, and the bone if it's bad enough. If that stays there long enough, the bone is going to start to resorb, and then you can get stress fractures. This is a typical progression of somebody who's under allopathic care. We can see the biomechanical ramifications of this. The feet are rolling in, they're dropping, the arches have fallen, they create the internal rotation of the tibia and femur, as you felt earlier when I had you stand up. And then we use our laser over the shin bones to get that muscle to calm down while we adjust the ankle, the foot, and the knee, and we support and we take away the cause of that stress, all right? Excessive pronation is absolutely part of this whole thing, all right? It is. I can't tell you how many times I've seen this in people. So you got to check those feet and the ankles and the knees. And it may be that they have a concurrent problem with plantar fasciitis somewhere, or they have something else. Many of these people come into us and they're a bloody mess. They have more than one issue. So you may be using your laser and your adjustments in other places too, all right? So shin splints with the walking cycle, the anterior part of your leg, that anterior tibialis muscle is active during your heel strike, your toe off, and your swing phase of gait, all right? It is basically active a lot. The posterior tibialis muscle is active just after your heel strike, prior to your heel lift. Anyone out there walking around can be affected, my friends. I know I put anyone playing sports can be affected, but that's just where we see it with more preponderance. Any human being out there, I don't care if they're a desk jockey by day and then they're trying to train for the leukemia or the breast walk, these people can get these things. So it doesn't matter who it is. You just got to know what to look for and what to listen for, all right? Just don't judge somebody. Oh, you sit on your butt all day at work, you probably won't get this. No, that's not always true. Now, we have some signs and symptoms. So history of change in recent activity. It's where I told you. Now they're ramping up their activity levels. Maybe somebody's training for a Spartan race, or they're training for a 5K, 10K, and they're upping their activities. Now they're getting shin splints. Bam, feet, arches, ankle, knee. What do I do next, okay? Gradual onset of pain that will worsen with time. Deep, achy, throbbing pain. And it's the location. You can't screw this one up. You can't screw this one up. It's right there on the front of the leg or the back of the leg, all right? Use your laser. I know that you will get certain patients in there who may look at you and go, well, I don't know. Hey, guess what? One of my marketing things that I've done, my friends, is that it's someone who I know very well in the office. I'm introducing technology and they're not quite sure. It's not going to kill me to give a few people a free laser to start them out. What I normally do in the office is the person buys a package, and the package consists of 7 lasers, of which one of them I give them free if they prepay for the other 6. I don't really care about giving one away, especially since it's been all gravy with this laser. I paid this thing off after a year. It's fantastic. So when they come in, I will put the laser on the appropriate area with the appropriate setting, all right? And I will go ahead and adjust their whole foot. And I will just look at the other types of things I have to do, whether I need to bring in some orthotic support, look at their shoes, ask them about their activity level, and guide them along this, all right? And there's the knee settings again. I leave the knee settings there, all right? And this is exactly what I showed you before, all right? Now, with shin splints, there's also some exercises that we can give them. They are simple ones that involve the ankle. And I also tell them to scrunch the towel underneath their feet or use some golf and tennis ball exercises, all right, where they roll their golf or tennis ball underneath their feet and massage the bottom of their feet. They can also lay on the ground and roll that golf or tennis ball underneath their leg. A lacrosse ball also works well, but as chiropractors, you probably have some kind of a toy that you like. Foam rollers are kind of hard down here on the leg, but, you get creative, all right? Osgood Schlatter. I'd be surprised if you didn't know somebody who had this, if not you yourself. More in boys than girls, but it's a development of the avulsion fracture at the tibial tube, all right? Right? You can see where the red mark is on this picture. That's your tibial tuberosity. That is where your quadriceps femoris tendon inserts. When we are young and we are still growing and our growth centers are active, when we have a forceful contraction of the quadriceps tendon onto that tibial tubercle, that can create excess stress, and the body lays down calcium when it's stressed out. That's where arthritis comes from. That's where bone spurs come from. That's where this sucker comes from, the Osgood Schlatter. Again, don't want to sound like yes, I do want to sound like a broken record. Pronation is a huge part of this. People, when you look at their feet, you're going to see them rolling in, all right? Now, pain, tenderness, swelling at your tibial tube may be present. You might have the swelling, you may not. Climbing the stairs, running, kneeling, possibly enlarged tibial tuberosity. I will use the laser here on people. It really helps. Now, when someone has a knob that looks like this, obviously I can't reverse the way that knob looks. They're always going to have that. But we can take care of the swelling and the edema and the inflammation in that area, all right? And return some of the muscles, stop having them spasm so much. So again, I love laser. I've had patients ask me for ultrasound. I told them, look, I'm not doing ultrasound anymore on people. I haven't done it for 8 years. Well, but my blah, blah said, I know and I respect what they say, but laser is the bomb. It is the best type of therapy that's out there. And I have seen this work in so many cases on so many parts of the body for so many people that I'd rather give them a free laser than subject myself to using that god-awful wand for 5 or 10 minutes on somebody, okay? But then we adjust the tibia, the patella, and the femur, and of course the feet if you can, all right? So when we use our lasers and we also do some taping, like look at that Osgood Schlatter brace. I usually will use sports tape around there, but that is an Osgood Schlatter brace. If you can get one that is tight enough, it'll stay there. Some of these braces, they fall down fairly quickly, and they become ankle braces after a while, all right? But again, this is really, really nice way of being able to help your patient. Now, with the rehab, it's pretty much using elastic tubing around the ankle bone and doing some dorsiflexion, plantar flexion, inversion, eversion under the exercise tubing resistance. You will do these types of exercises later once you flare down the acute nature of this. All right, you have to get that swelling and stuff down first, and try to give some kind of support underneath the feet somehow so that the pull will be reduced on that quadriceps femoris. Okay, again, here's the settings. Yes, this is meant to be a broken record to you, so you can see how I use similar settings. and they repeat themselves. It's just meant to make you like, oh my God, if I get this laser, am I gonna have to like have a different setting for every like single part of, no, you don't have to, and they're programmable. Your rep that you're getting your laser from will help you figure all this out. I know a lot of the reps for Cutting Edge. They're really nice people, okay? And think about it this way. Why did I buy this laser in the first place almost 9 years ago? Because I want to have the greatest technology in my office to show these show these patients that I'm awesome, that I do a great job. And I want to be awesome because I just love trying to be the best. It doesn't mean I am, but it means I'm sure as hell going to try. And this laser, time and time again, it's amazing how she's almost 9. My laser's name is Kathy. I named her after the first patient where it changed her life. And she came in from multiple parts of her body almost 9 years ago now. But I named her Kathy, and Kathy, she gets serviced regularly, so she's still cutting edge. She's still the greatest laser out there, and it's been really, really fun to have her with me in practice. Okay. There's also a setting for muscular contractions. So you want to get a little more specific on that tibialis anterior or the tibialis posterior, the calf muscles, and use the muscular contraction type settings too. But again, what do we have here? The pre-settings on my machine, I finally figured out years later, are really just guidelines. When you learn how to manipulate those settings, as your rep will help you learn or as you have learned yourself, it doesn't matter that it says muscular contraction. I can manipulate this to 100%, 800 hertz, 5-6 minutes. It'll give me the appropriate amount of joules. And when I get my X and Y, I could have a similar setting for low back, but I know low back is thicker. So this is where those presets came in the early versions of the lasers. The reason why I think they went away from that is because they give you more autonomy to be able to control your depth and your penetration by being able to set your own settings on this, all right? So look, this is one of those rare indications where I showed you 50% on there. I don't use 50% very often, all right? There's a muscular strain inferior limbs. Oh my God, look at the correlations again. I'm showing you something that's not real big news, all right? Look, it's pretty much very similar. It's just now when I changed the time and boot it up to 8 minutes, okay, on pretty much the same percentage and the same hertz, now it bumps the joules up, okay? And look, I changed the amplitude a little bit to get my surface area. You got this. It's not that hard, and it's so fun to integrate this technology. All right. Let's get to the last part of this. It's the hip. Your hips are always indicators of what your feet are doing. I really hate to tell you and keep going back to the feet, but my world is the feet and shoulders. That's where I live. Why do I live there? Because so many chiropractors have issues treating these areas effectively. All right. And that's not even saying anything about the allopaths and the other types. We have some people that specialize in these areas, but I know biomechanics and I know how this stuff works, and so do you. So you and I, we can own this stuff if we just look at our patterns and understand what's going on. When someone's standing and they roll their feet down or their feet are collapsing, all right, and you did a mock-up of this earlier in the webinar, you can feel the tibia bones turning in and the femur bones turning in, and it pulls the heck out of that hip, and it rotates your pelvis and goes right into your spine. So this is why so many people are shocked when they come into my office and they learn their back and hip pain are actually coming from their feet, all right? Now, doesn't mean that you can't be playing in a football game and somebody rams their helmet into your hip and now you have pain. That's a little different. Or some of your people that play sports. Someone who falls or someone who has contact injuries, that's different, right? Now, the hip is a nice, deep ball and socket joint. It's surrounded by the it allows the upper leg to move smoothly. And it has a lot of cartilage, muscles, and ligaments. It's the largest weight-bearing joint that we have. It's really amazing, all right? And there's your anatomy. There's your femoral head, your neck. There's that nice acetabulum. It is a very deep joint. It's a deep socket, and it's a very stable anatomy. You got thick joint capsule, strong ligaments, very powerful muscle groups around there. The joint itself is rarely injured. Most injuries are due to secondary to biomechanical. Oh my God, biomechanical? Do you deal with biomechanical? Yeah, you do all day. All day, and these patients don't realize it until you point it out. Your patients, there are a lot of them out there that don't still realize that we have 3 arches underneath our feet. You know it, but they don't know it. Oh yes, the ones that have come from the foot doctor still don't know we only have that. They still think we only have one arch. They've never been taught this stuff. So look, we follow our little bouncing ball from the feet to the ankles to the knees up to the hips now, and look at these things that you deal with every day. Iliotibial band syndrome, tensor fasciolata, which is the muscle component of the iliotibial band. If your ITB is the tendon which extends from your greater trochanter all the way down the lateral part of your leg, the tensor fasciolata goes from your ASIS to your greater trochanter. Get in there with your fingers and feel the 45-degree angle that muscle takes as it goes from your ASIS and inserts onto the greater trochanter, okay? You can have bursitis of the greater trochanter. You can have a capsulitis of that area. You can have the hip flexor muscle strain, which is your iliopsoas. The iliacus and the psoas major come together down there. The hip adductors can be strained. Your piriformis, and also there's anterior pelvic tilt that happens when you are pronating too much. Again, people that pronate out there, it's 8 out of 10 people. People that supinate is 1 out of 10. And people that have healthy feet at any given time is about 1 out of 10 as well, all right? So this is why it comes in so often. I'm not making this stuff up. It's just what I see. Now, the hip itself, excessive pronation that you have when your arches have fallen and you have internal rotation of the tibia and femur pulls that femur head and puts stress on your lateral hip. Now, how do I screen for this? I know my pattern, so I usually don't have to screen for it, but if I'm trying to guess, or the person's a really mild pronator and it's hard for me to kind of tell, I'll have that patient supine, all right? I will take their leg and I will grab their foot, lift it off the table, and rotate their entire lower extremity, internal and external, and I will feel through the leg at the femur bone and find out if they're stuck on the internal or stuck on the external rotation. I can compare bilaterally, all right? This is a pretty common test that a lot of us have done before, all right? Now, we will treat the hip accordingly with the same things I told you about before. With the laser, use your adjustments, support with orthotics if you feel like that's important or not, and then you can rehab them. Here is the hip setting for my laser and for yours as well. It's 100% intensity. It's a 1500 hertz. If they're painful enough, I will bump that puppy to 2000, and time is 10. You don't need to do really laser over 10 minutes on anybody. The thicker the body part, 10 minutes. Thinner, you go to 8. If it's real thin in the hands, it's 5, okay? Remember, it's not a matter of over-treating. It's a matter of it's just not going to do much else at that given time on that day, all right? And there's your joules of energy that's coming. It's getting about as much as we will get on there. Lower back is probably just a little bit more, all right? Now, there's the picture on the right of that test I told you about the testing the internal and external rotation of the femur. I'm grabbing, this is my daughter at home with her kung fu pants on, and I'm grabbing her foot, and my hands are underneath there, so I'm going into internal and external rotation. And guess what? If I find it stuck in internal, I'll go all the way to external, and I'll give it a yank, and it'll open up the hip. If I find the hip bone stuck in external rotation, then I'll pre-stress internal and give a yank and watch it open up. All right. On the left is me with my knees squeezing in on the distal tibia while my hands hit the middle to proximal femur. And what do I do with my hands? I can pre-stress internal or external, depending on how it's stuck. Say that the person is internally rotated, as I mostly find on just about everybody. I will take my fingers now, I'll grab their thigh, and I'll go from internal to external rotation and use my legs and yank. So that's another way for me to adjust someone's hip if they're a larger person. Or if I want to stabilize the knee and just use my hands if somebody's had a knee replacement and I don't want to pull through that knee, all right? If someone's had a hip replacement, I normally do not do this at all right? Okay, there's a lateral femur adjustment. I'll cock the jaw piece if I find the femur head to go a little bit lateral. I can also take out little posteriority with this move. I just cock the jaw piece. And if I don't want to hold the leg up, I can put a pillow between their knees and leave the leg down and just do basically like a single hand contact over the greater trochanter of the femur, driving lateral to medial and a little bit posterior to anterior for the posteriority of that hip, all right? Anterior femurs are where you're going to find these people complain about inguinal or groin pain. You get in there, you have them bend their knee, and you palpate with your fingers first. You can find that femur head go forward. It happens. So then what I do is I set the drop table up, or if you don't have a drop table, I didn't mention this when we went to the knee. If any of you don't have a drop table, you can actually use your portable speeder boards, or they also make portable drop pieces that you can get. They're not that expensive, where you can put that piece underneath there and use that to drop their body part. So I cut the drop piece and give it a couple sets so you can feel that femur head slide back. It's actually pretty nice, all right? All right, sciatic neuralgia, very, very common. Again, you and I both know as field doctors that people will come in saying that they have sciatica when they truly do not have it because of the pain pattern that they're pointing to makes no sense. It always makes me wonder who the heck told them that. And I just stopped asking after a while because it's just, sciatica only goes down the back of the leg. It's the sciatic nerve distribution. It's not the side, it's not the front. Side and front is usually sacroiliac in chiropractic terms. You and I both know that's the pattern for sacroiliac. Okay, so I'm actually more excited when they're wrong about their sciatica because it's a heck of a lot easier for me to fix a side joint than it is to sometimes deal with the pure sciatic. It's going down the back of the leg, the knee. All right, it takes effort to really help them. So that's usually one side or both along your sciatic nerve distribution. What could cause it? You can have peripheral nerve compression, intervertebral disc herniation, DJD, which is your arthritis, excessive pronation, of course, because that truly is something that will stress out the lower back and the hips. Injuries and spondies, all right? Spondy could cause this. You know, most of the time I shouldn't say most, many of the times that we see people, their spondy is in an inactive stage. One of the things that we're learning is that when spondylolisthesis is in an active stage, that's when you have to be careful adjusting that person because you could potentially move it. There's a lot of people where it's been inactive for so long, it doesn't matter what you're going to do there, good or bad, you're not going to move that spondy anymore, all right? So for sciatica, that's truly sciatica. We've got increased pain and numbness along a dermatomal pattern of the sciatic nerve, the back and side of the leg, possibly below the knee. You've got motor weakness as a possibility, diminished reflexes, sensory loss, muscle atrophy, and the piriformis syndrome. This is really cool, not only from a treatment standpoint for chiropractic, but also for our laser. Because when we stick our laser right on this piriformis, holy smokes, this can really help us. 80% of the time when sciatic neuralgia is present, to some degree, the piriformis is in a spasm or in a hypertonic state. This diagram here will show you how someone who's pronating and has that internal rotation of the tibia and femur, as it pulls and tethers the piriformis muscle, it'll hit it and make that nerve get more irritated, all right? So again, I told you I live in the world of the feet, creating a lot of problems. I don't make this stuff up. I figured it out, and I learned over the years just how much of an influence it has. And I don't want you to miss it, just like I don't want to miss it anymore, all right? So the piriformis is a spasm of the piriformis muscle due to non-traumatic injury. Can cause anywhere from simple buttock pain to full-blown sciatica, all right? Full-blown sciatica. If someone is sitting in the chair and they cross their legs a lot, that's not good. That is one of the main things that we have to change, and you will be so surprised. No, you probably won't be surprised at how many people sit with their legs crossed. You might be doing it right now. Yes, catch yourself. Uncross your legs. But these people don't know why they shouldn't cross their legs until you tell them. There could be some pelvic rotation, again, coming from the feet. Could be excessive foot pronation. Could be an anatomically short leg, all right? That's possible. That's possible. Now, what are your signs and symptoms? Low back pain, buttock pain, hip pain, posterior thigh, leg, foot, sometimes the groin and the perineum. The perineum are the privates. That's no fun, all right? And again, there are our lasers. There are our friends to help us with our day. Oh, here's the other reason why I switched. I wanted to get the M5 and the M6. It's because they're unattended modalities. I run my office by myself. I don't want to have a therapy person back there because I just don't really trust some of these people to do the job that I need to have done. That you might say is my own problem. And that's another seminar. But what I'm saying for you is having the therapy that you can set and forget and walk out of the room for 10 minutes, you're treating somebody else, and you don't have to pay anybody to do it. I run my own office in the back. I run 3 rooms at any one time, and I book patients every 15, and I double book to half hours, and I can do that with having the laser and with being able to do it by myself. So anyway, that's just my practice. So we can adjust the patient, hip, knee, low back, and the feet. There's your lumbar settings. Bam. Now, I do not have the frequency turned up to 2000. That will raise the joules a bit on this. My time stays the same, never more than 10 on the thickest body parts. All right, you don't need it. There's the lumbosacral arthritis setting. All right, pretty similar. All right, again, it's not just not a lot of you can see how the hertz will go up to 15 for this, and it changes the energy a little bit. The computer, I mean, the laser knows how much energy to put in there, and then when you control your X and Y amplitudes, again, that's the area that you're covering. All right. So there's a couple stretches that I really care to show you about. One of them is that one when the person's sitting in the chair. That's probably my number one exercise I show people to help to stretch piriformis and glutes. They cross their leg, man style, man spreading. Then they bend forward at the waist, making sure that they don't crumple their back. They get a really nice stretch in there. The one below that, for those of you that do yoga, is called the pigeon. That is the best piriformis stretch, I believe, out there. It's just that some people will not be able to get into that position, or they won't be able to get back out of that position. So I caution you to be careful with that. All right. All right. So let's see. So as we get to the lumbopelvic area, there's your pelvis, there's your lumbar spine. The common areas that we get here that are involved are the sacroiliac joint, the sacrum, and the pubic symphysis. The pubic symphysis may not come to you a lot, but when you have a pregnant female, make sure that you are checking this area, because especially as you're getting to the later stage of pregnancy and right after childbirth, you may have to adjust this with the activator or some type of a light adjustment. All right. So we have common conditions for the low back as we hit this is the last part, the sacroiliac joint and the disc degeneration. That's some of the common things that we come in to see. You and I both know how to diagnose sacroiliac joint. Some people will say that it's in that general area, but we'll know whether it's moving or not. Arthritis comes in all the time. In fact, arthritis gets blamed for things that it has no business being blamed for. It's just too much of a overused and misused diagnosis for people. And this is the reality of it. So we use our laser again around that area in the SI, the ilium, the sacrum, the lumbars. Yes, you can do it on the pubic bone. I don't do it there very often, but it is totally safe. All right, it's totally safe. It's just you have to look at your situation. And again, with the adjustments, you have your classic side posture, involves side up or down. The side posture involves side down is something I show every time I get in front of people. It's a very slick move. Some of you have learned it in school, but some of you haven't. Maybe someday I'll get a chance to show that to you. But you know, also side posture with the sacrum, or you can use your drop table on any of these things, the lumbars, the pubic bone, and the dreaded coccyx. Hopefully you don't have to work on the coccyx, or hopefully if you do, it's all external, because we all understand that we don't really enjoy some of that other stuff there. So, okay, using sports for the lower back, it still works. Lumbosacral support belts will work as long as they don't wear them all the time. There are some people that believe you can weaken the lower back muscles with the lumbosacral support belt. I don't happen to think so. Unless somebody wears it to bed and they wear it 24 hours or 48 hours, I mean, that's a lot there. I usually just have them wear it when they're going to be sitting in the car. Take it off when you get home. Don't wear it to bed, that kind of thing. All right. The orthotics for the feet to support the feet and reduce the stress coming from the feet. That's one thing that's important to me. And of course, the stretches are the strengthening. All right. So it's really important to me that I try to take the time to explain things to you as much as possible. I really enjoy this, and I love using my laser. And I hope that this has kind of stimulated you to get excited about using the laser in other areas. In our last webinar that we did, the first one, we went over feet angles and just started to barely touch the knees. That's why I wanted to cover it more here. Trying to give you a comprehensive look so you can go back on these webinars and just knock it out from ground up. So if you've got questions, you can contact me, or go through Cutting Edge, and if you want to get a hold of me, not a problem. But it's my pleasure to be here for you, and I hope you've gleaned something useful out of this webinar. and have a fantastic day.
Thank you, Dr. Wong. That was great. Thank you, everyone, for your time, and we look forward to the next webinar. Have a great afternoon.